Welcome everyone. We have a really exciting webinar which is very close to my heart today. It's looking at how we can unlock the potential in the ERNs using disease-specific outcome measures. We've got three presentations with Q&A in between. I'll just set the scene quickly and then we'll move on to a stellar lineup of speakers. We will have best practice examples given from Connect, the Rare Kidney Network, and from ERN, the Rare Endocrine Network. And then we'll have some feedback and a presentation from Johan about how patient representatives involved in the ERNs have helped develop some of these outcome measures. I'll do the introductions as we go through rather than all now, if that's okay. So setting the scene, the ERNs have grown as clinical networks across Europe. We've got 24 networks covering over 1,000 conditions operationally. Strategically, they're covering all, but operationally, we've got clinicians connecting for at least 1,000 conditions on a weekly or daily basis. The 24 networks have over 1,600 expert teams taking part in over 380 hospitals in 27 member states plus Norway. And we have patient representatives, nearly 400 of them active in the ERNs. You add all those people together, really the knowledge, the cumulative knowledge is significant. So how can we really unlock that knowledge so the networks go from good to great? At the heart of the networks is we've got a continuous monitoring framework, and this is how it was set out from the original assessment to recently the 5-year evaluation. In between, we had the European Commission developing a continuous monitoring framework in 2 parts. One was some common indicators. We call them 18 indicators. And these were what all the networks had to do, collect data on and report. And these were more around the coverage of the networks, how many case reviews were being done, how many guidelines being developed, etc. So really sort of output or activity-based information. But that was only the first part of the continuous monitoring framework. The ambition was, in the second part, was to develop more disease-specific outcome measures. And today we'll have ERCnet and ERN outline how they have developed those measures in their networks and the value and use of them. But just to give you an example, you know, I've been active now in the ERNs for 10 years, way before the networks came into existence. And the reason why I'm so excited about the ERNs is because I've seen how disease-specific outcome measures really can unlock the potential and see the outcomes of care improved by 10, 20, 30% in some cases. This is an example of some disease-specific outcome measures which I was involved in the UK. We had set up a neurofibromatosis type 2 national service of 4 centres. Type 2 is the tumours are on the central nervous system and in the skull. And we had the 4 centres come together and agree 5, I think, measures which told a story about the condition. So these outcome measures were around time between the first presentation of the symptom and time to surgical intervention, time for serviceable hearing, so how long people could really use their hearing without it being affected because of the tumor growth on impacting on the cochlear nerves. Facial palsy was a measure that people had a less than 20% rate of facial palsy because any operations going inside someone's head, there's a risk of nicking a nerve and causing some paralysis. using hearing implants. So the service also looked at doing cochlear implants and auditory brainstem implants. So when the nerves were damaged, people still could hear, and also disease mortality. So these 5 indicators, we agreed with the centers, and they collected all that data, 100% data completeness, and they had to profile it against their case mix and present it to each other. And by doing that, the centers could learn when one practice in one center was having better outcomes than in another. And you got them to share their knowledge, and people adopted that new practice quickly. We saw by doing this in the 2-3 years I was doing the service, looking after the service, we saw the development of surgical philosophy, going in and doing total tumor debulking early rather than watch and wait and doing partial debulking, the use of Avastin. We saw that they were best used for faster growing tumors, and it wasn't an alternative to surgery, but it was more of a strategy to stop people from being treated, having surgery through the teenage years. And other examples was we learned that actually using a cochlear implant on a damaged cochlear nerve had a better result than having a brainstem implant, auditory brainstem implant. So this learning really took forward the outcomes and quality of life for people going through the service. So I believe, and that experience in the UK has left me excited and believing that the disease-specific outcomes are really the future, and a way to sort of harness the collective knowledge of experts in ERCnet and in all the networks, in fact. So we're having this webinar today really to learn how 2 networks have focused on this, what their experiences have been, and I will shut up and we'll move on to the first presentation. So we'll have Tanya, and I'm going to say your name very badly, the second name, Tanya Volskovsky, who's a research coordinator in ERCnet, and she will share the experiences that ERCnet have had with these measures. I will stop sharing so you can. Apologies for my pronunciation.
No worries, it's Vlodkovsky.
Yeah, thank you.
Okay, so good afternoon, everyone, and thank you for the kind introduction and for the invitation and having me here today. So as you heard, my name is Tanya Vlodkovsky, and I've been working with ERCnet as a project manager since 2018. And over the next 20 minutes, I will present you how ERCnet developed a key performance indicator, outcome and indicator monitoring tool, and how the system impacts the patient management within our network. Here you can see the agenda for my talk today. First, I'm briefly presenting ERCnet, the European Rare Kidney Disease Network, its structure and the main objectives. Then I will go a bit into detail in our efforts to harmonize the disease management within our network. And then I will present you the key performance indicator and monitoring tool, its selection process, the integration in ERCREC, and the monitoring and reporting mechanism. And as a last, I will present you some practical quality improvement projects based on these KPIs. ERCnet is one of the 24 European reference networks for rare and complex diseases that were established by the European Union in 2017. Currently, our network includes 72 centers with having 100 units, serving approximately 70,000 patients with rare kidney diseases in 24 European countries. We also work closely with 33 European patient advocates, our EPACs. And here in this slide, you can see our organizational structure. We have 9 thematic working groups focusing on various kidney diseases. These working groups are composed of clinical expert and patient representatives. And we are also having different task forces focusing on areas like molecular diagnostics, pathology, education, research, or the registry. Our EPEX leads, Susana Carvajal-Ariona and Uwe Korst, along with Valentina Neukel, our ERCnet patient engagement manager, ensure that the patient perspectives and needs are integrated in all our core activities. Here you can see the key objectives of ERGNet. First, we offer virtual expert advice and support through a virtual consultation platform called CPMS, which is a platform offered by the European Union. We also offer comprehensive training programs like webinars, e-learnings, or exchange programs. We promote research through our registry, surveys, and we also foster patient-driven research projects. We also have a comprehensive multilingual disease repository on our patient website. And a major objective is the harmonization of the patient management across our network, and we achieve this by adopting and developing guidelines and also monitor the center performance and the patient outcomes through the KPI system integrated in the registry. So I will go a little bit now into detail in our efforts in the guideline development. So this includes first the formal endorsement and review of existing guidance documents. We do a gap analysis and also start developing our own guidelines where there is a need. We disseminate the guidelines through our network. After it's formally endorsed by the network board, we publish them on the website. And whenever there is a webinar related to the guideline, we also link it there. And we will also make them soon publish on our ERGNet guideline app, which will give an easy access to the guidelines, recommendations, and clinical decision pathways in your pocket. The guidelines are all adopted and implemented in the ERGNet centers, which are committed to adhere to the guidance documents. And we monitor the center adherence to the guidelines through our KPI tool, to which I will come in a second. So here you can see the landscape of the rare kidney disease guidance documents. So before 2020, we have mostly or only endorsed guidance documents which were developed from other renal societies. And when we started to publish them from 2020, you can see that the ERGNet guidelines are the leading source for the guidance documents in the rare kidney disease area. So in the last 4 years, we have developed 14 guidance documents and published. 14 more are currently ongoing in different stages, and we have other 5 proposals which are in the pipeline and just about to get started. So having outlined the importance of the clinical guidance documents in having a standardized care, we needed a mechanism to effectively monitor those the center performance and the patient outcomes. And this is where the KPI tool comes into play. So what are the key performance indicators? These are quantifiable metrics that reflect the ERGNet center performance on clinical practice and patient outcomes. And the KPI tool aims to harmonize and optimize the management of patients with rare kidney diseases throughout Europe. And the monitoring tool is integrated in our European Rare Kidney Disease Registry called ERGREC. So why is ERGREC the ideal source of having such a monitoring tool? So ERGREC is a centralized online registry, not only for ERGNet members, but also for all interested hospitals around the globe. We collect a basic data set relevant with information for all patients with rare kidney diseases, but also we are collecting disease-specific information. The registry was opened in 2019, and since then we have enrolled more than 25,000 patients at 100 units in 24 European countries, and our enrollment rate is also quite high, with having 100 new patients added per week. So having the KPIs integrated in our ERGREC allows us to track the patient care, the center performance, and also the overall ERGNet performance. So the development of the KPI monitoring tool was a thorough process. So we have started to compile a tentative indicator list, which was proposed by our task force registry and outcomes. And in the beginning, we had 54 proposals for the different working groups. We then did an indicator assessment and evaluation through a Delphi survey, which was sent around to our clinicians and also the patient representatives. And it was evaluated against the dimensions of priority, like how important is it to monitor in the registry, the validity, to what degree does the indicator actually measure what it's supposed to measure, the reliability, will the results be the same measured in different hospitals, and if there is a relevance, and also the feasibility, how easy is it to obtain the data required to determine the indicator at routine clinic visits. We had then 40 KPIs fulfilling a predefined threshold, which were then selected, and we had defined the target ranges and also the parameters that need to be captured in the registry. And we finally integrated the tool in ERN, which allows us to continuously track and analyze the KPIs whenever a patient is entered or being updated. Then we have the continuous monitoring in place, either through a continuous self-assessment by the center itself, or also a regular assessment of the KPIs from the working groups or dedicated task forces, which allow real-time performance trends and also act if there are a need for improvements. So here you can see how the KPI tool looks in the registry in the center dashboard. Currently, our monitoring tool tracks 64 general and disease-specific key performance indicators. The tool provides detailed statistics for each participating center, allowing to track their own performance and compare it to the ERN average. And we have also included an online export function for the centers for their convenience to see which patients do not meet the criteria so they can promptly intervene. In addition to the continuous self-monitoring, the ERN Central Office also providing twice per year a PDF report to the centers, allowing them to review, discuss with their clinical team, and also identify areas for improvements. And in my last part, I want to show you some practical improvement projects we have conducted based on the given KPIs. So the first one is on the KPI with the percent of patients with multi-drug resistant nephrotic syndrome receiving comprehensive screening. The target range is more than 50% of those patients should get genetic screening, and we saw in our ERN overall performance that the adherence was quite low. What we did is we sent out queries to the relevant centers, asking them to review the data and the data the patients and the data entered. And what we could reach was a very high significant increase in the KPI compliance, either through the corrected data in the registry or the patients were subsequently considered for genetic screening. My second project is an ongoing initiative, and it's on patients, children, which are small for height with chronic kidney disease or on dialysis receiving growth hormone. We saw that only 20% of those children actually get the growth hormone therapy, although it's recommended as the first-line therapy. So what we did was we identified all the patients and sent out a survey to all the centers, asking them for each individual patient for the reason for not administering growth hormone. And to our, we were very happy to see that within 1 week we received 50% response rate, which account also for 50% of the relevant patients. And on the pie chart, you can see the reported reasons for not administering the growth hormone therapy. So a significant proportion could not get the growth hormone therapy because of medical contraindications such as syndromic diseases or neurological impairments. And also big portion of the patients had wrong data entry, so it was corrected subsequently. And also a very significant portion of patients of 16% have started the growth hormone therapy upon sending the survey or after the last visit they had entered. So what we will do next is we will do a follow-up monitoring of the unexplained patients. This is, for example, for the 77% of patients who would be qualified to receive growth hormone, but it was not proposed to the parents. So we will go back to them and also share the best practice with them. And we will also go back to the patients that were reported with a scheduled transplantation, whether the transplantation was performed or the patients are in the meantime on growth hormone therapy. And as an overall monitoring, we will do again a survey in 1 year to see the overall performance change. So, and in my last slide is just a very complex analysis. I just want to show you what we are currently doing in the central office. So our statistician, Jonas Hofstetter, is currently analyzing systematically all our 64 KPIs. And here you can see the percent of patients meeting the KPI across the ERCnet centers. So we just want to show you that there is actually some kind of variation in the KPIs, and doing such analysis will allow us to identify areas for improvement, sharing best practice, going back to the centers, and just improving the patient outcomes. And this is my last slide, my summary. So ERCnet has established a powerful tool to review the center performance and patient outcomes. The KPIs helped identifying areas of excellence and those requiring improvements. And the integration in ERCrec maintains the highest standards of care and also drives targeted quality improvement projects. So I want to thank you for your attention. You can reach us under this email address, and we are also active on social media, so please follow us to be updated with our activities.
Thanks, Tanya. I have to, I'm always impressed by how you've got your registry up and running and how much your centers are, putting patients in there, the data in. You must have a secret to the success of of really integrating the registry into all centers, because 100 new patients a week is a lot, really.
Yeah.
I'm sure that's a whole different webinar to unlock the secret of your success with the registry, but it's really impressive. I'm going to not go into any specific questions now. I invite people to put questions in the chat, and Nora and Andrea, we can keep an eye on them when we come back to them and open the floor up as well. But thank you very much for sharing how you've used these outcome measures, you define them, and how you've used them to improve the care which people receive in the centres. So I'll come back to you with some questions in a bit, but I'm going to ask Faisal and Anna. So we have Faisal Ahmed and Anna Prego from Endo ERN, and they've been leading the development of the registry in Endo ERN, and will explain about the value of these outcome measures.
Thanks so much, Jan. Matt. What we'd like to do is a double act over here. So Anna Prego and myself are going to do it. Anna's based in Leiden. I'm based in Leiden as well, but I also work in Glasgow. Anna, you're going to share the slides, and she's going to give me control for the first few slides, and then we'll take it that way. So our remit, just like Tanya's, was really just to give you an idea of what condition-specific or disease-specific outcome measures are, how we're developing them in Eureka, which is our registry linked to Endo ERN, but also we've merged with ERN Bond. So what we do really applies to both Endo ERN and ERN Bond, which are two registries. Let me just go through this. So there's a kind of a delay in the movement of the things. So yeah, so I'm going to give you some idea of the a bit of background of the registry itself. And if I call it Eureka, just know that it applies to ERN Bond as well, which was Eurobone, and I'll show you how the two registries have merged. And nowadays, we're referring them to Europe, but myself, I'm going through a transition. So these terms are all interchangeable. And I'll also, Matt touched on this a little bit about the rationale for care quality indicators, and I'll go through that a bit as well. And then Anna can give you a bit more hands-on sort of information about how the registry platform is developing and how we can use it for these quality outcome indicators. Yeah, so, oops, this is a little bit, seem to be going forward. Let me see if I can go back on this. Give me a second, it's just that I'm controlling this from a distance. Yeah, so when registries are developed, they can have multiple purposes. And Matt mentioned earlier on that maybe ERC-Reg and Eureka are a small number of registries which are actually focusing on quality outcome indicators. And I think part of this may be based on the fact that a number of people, when they develop registries, tend to develop it for a number of different reasons. And sometimes they're not completely clear as to, when it comes to improving clinical outcome, that perhaps there is something which they need to focus on, because people try to develop them for understanding pathogenesis and natural history of a condition. Sometimes they develop it for improving diagnostic yield. But of course, there is short-term and long-term outcome, and that is very closely linked to assessing quality of care. Some people use it to improve the case for service development. And then a lot of people tend to use registries for research. And I differentiate research from what we're talking about today, which is about improving outcome. Of course, there's a link there, but they don't necessarily have to both be very, very seriously closely linked. And when we talk about research, it can be epidemiology, genetic, or molecular. Obviously, registries can help with clinical trials, looking at other drugs and devices. And of course, lastly, they can connect patients, families, clinicians, and scientists. So registries can do lots of things. And at the moment, as that little sort of GIF is suggesting, everybody wants a registry, but what they're not completely clear about is why they're actually wanting a registry and what's the purpose of that registry. So that is something which needs to be clear. I think what ERNs are focusing on, or should focus on, is very much trying to understand short-term and long-term outcome, and improve the quality of care, assess it, and then improve it. And that's where the ERN mission is very much. And all those other things which you could say a registry should be doing, somehow the end effect should really be very much about improving outcome. Okay, and we're talking a clinical outcome, whether it's short-term or long-term. But that's effectively why we connect people together, why a registry develops new drugs or helps in developing drugs or whatever research it is. But the end point is very much improving outcome, okay? And that's clinical outcome. Whether it's short-term or long-term, that's another thing to think about. And of course, you can only do that by assessing quality of care. And this is not just myself who's made this up. And if you go back and look at how ERNs were created, then there are a few different indicators, and Matt touched on that. And I'm specifically highlighting two indicators over here, which is 2.1 and 8.1. The 2.1 was the point that these registries, which ERNs have, should be assessing total number of new patients. And so this is like quantity, yeah. And of course, it has some bearing on care. But the objective 8 was the critical one, which was complex and long-term indicators. And at that point, when this was being developed, it was basically a blank space over there, and it just said level of patient satisfaction. And that was at that point to be developed, okay? But of course, things have moved on since that early time. We're talking now 5, 6 years ago now that this was being developed. So we're talking the 2.1 is very much quantity, and 8.1 is quality of care. Okay, and those two things need to be differentiated when we're talking about KPIs or key performance indicators. And when Eureka was, oops, we've kind of gone. This is really very sensitive, but if I can go back, one slide. And it might be easier just for you to control this. Because I think there's a delay in time between yourself and myself. Yeah, can you just go back? That's great, thanks. Just keep going back. Keep going back, keep going back. Yeah, just stop there. Yeah, stop, yeah, that's fine, next slide. Thanks so much. So when we developed the Eureka, we wanted to do both. We wanted to get quantity and we wanted to do quality. Now, to do quantity, to assess quantity, you need something which is very simple. Okay, so this is where we developed ERN, okay, which was collecting information on first encounters. Okay, and this didn't require consent from patients. Okay. So this was a very light touch registry, and that was developed in 2018 and launched in 2018. And that was basically asking centers, have you seen a case of whatever condition endo-ERN is reference centers are encountering? Okay. And that was a pretty simple thing. And this got now something like over 36,000 patients who've been registered in that. And now endo-ERN is using it as their continuous monitoring exercise for centers. Okay. So that works. And of course, the other side is the core registry. The core registry is where you can collect outcomes, okay, and that requires consent from patients, and that's got something like 3,500 patients now in that. So you can see that to assess quantity, we've got a very simple process and a registry, and for the other part, we have a slightly more complex where you require consent and things, but it's also working. Okay, right, next slide. So this is what the structure of Eureka was and how it linked up with the endo-ERN. And that effectively is pretty similar right now, where we've now got ERN bond in it as well. And this is where we developed links with urologists, and you can see that Matt was involved in that as the independent advisory board. And we had a particular sort of focus over here on core clinical outcomes. And what we did was we asked our expert working groups, which had expert sort of patients as well as expert clinical people, as to what were the important things which you think are useful as outcomes go, okay, core outcomes. In a number of these expert working groups, it was quite difficult to come up with a consensus as to what it was. But for example, in adrenal, it was clear that one of the outcomes which people really wanted was sick day episodes, okay, and some of the people may know about adrenal insufficiencies, and our sick day episodes are so important in that particular one for patients to avoid, particularly children. Okay, so we took that on board when we was talking about that. Next slide, Anna. Now, if you go back to how endo-ERN and Eureka, the registries, link up, this is a complex slide, but it actually takes you just through that process. So we started somewhere around 2016, 2017 on this journey, and we're now, of course, moved on. But you can see on this particular one that the white bits, the white boxes over here, are the kinds of things which endo-ERN was doing for what it was being told in blue as far as what should be done. Okay, so we need to be thinking about some sort of minimum information which can identify volume of activity. Okay, there needs to be something which is specific for the conditions. Okay, and then we need to be performing surveys, and then lastly, we should be thinking about clinical benchmarks. Okay, and this requires expert discussion, and this is what will inform the development of these patient outcomes. So the level of difficulty which is involved in collecting information on quantity of how many patients you're seeing, how many investigations you're doing, that's really quite easy to our centers, and they can provide you. Okay, it may be complex, but actually it's relatively easy compared to quality of information, quality of care. Okay, so for that, there requires to be a lot of stakeholder involvement. There needs to be a push from stakeholders as well to say that, look, this is what we want the registries to collect, and there is agreement in that as well from patients as well as clinicians. Okay, so you can see that this is the kind of pathway which Endo-ERN has been adopting. Okay, and the next slide. So where we are is, if you look at how we've developed, so from 2017, when the project was approved, we developed the ERN core registry. And then around 22, we merged with Bone itself, ERN Bond. So now you can see that one registry or one set of registries, EREC and the core registry, can serve the purpose of more than one ERN. Okay, there's nothing magical about these registries in the sense they don't necessarily have to be linked to one particular ERN, because the platform is very similar. And there's, of course, there's a professional overlap as well between these two ERNs, that we thought that we could serve the purpose of both ERNs with one registry. Okay, and now the question really is about long-term sustainability, and because we've consolidated the whole project itself. And when we talk about, next slide, Anna, when we're talking about long-term sustainability, it really we need to be really clear, what are the registries for? And this is where it comes down to this business of disease outcomes. Matt earlier on mentioned about the fact that he'd been working in the UK, looking at some sort of outcome indicators and some dashboards and things. Well, I've been working in Scotland. Matt mentioned England, and I've been working north of the border in Scotland, where we've been developing similar dashboards. And these are the projects all in blue, which have been going on for some time, where we've used data sets which exist, but also developing care networks. And the purpose of these care networks, or managed care clinical networks, is very much around trying to improve the care of patients. So these were the lessons which we were bringing into Eureka, is to actually apply those lessons itself. But in the meantime, over the last 15, 20 years, I've also been working on another European international project, and I'll give you some examples of how they've been using benchmarks. So these are the projects in orange. Next slide. So in here, this is a project which is IDSD, ICH-ITS, you can call it that. But this is a truly international project which goes across the world, and there's something like 46 countries, putting in cases from 152 centers in all parts of the world from different continents. And I want to focus on CAH, congenital adrenal hyperplasia, which is the top condition over there, which is marked with green. So this is a condition which is associated with adrenal insufficiency. And you know, when we were having our consultations initially, we were told that adrenal insufficiency, sick day episodes, is an important area as something which bothers patients as well as clinicians in trying to reduce this, particularly in children. So if you look at the next slide over here, what we've done over this time is to develop a number of different benchmarks. And so this is a very data-heavy slide, but if I take you to the left first, what we can look at is geographical and temporal trends in hydrocortisone dose or glucocorticoid dose. And you can see there are differences between countries, okay, as far as how much hydrocortisone they use in their own countries. But you can also see that in the bottom panel over there, that in different age groups over time, the dose of hydrocortisone has reduced, okay, particularly in the younger age group. Okay, so this is happening. And we can provide this data at a country level and a center level as well. So now in the top two panels on the right, you can see that we're looking at sick day episodes per patient here for the different countries. Okay, and you can see that there are differences also between high-income countries and low-middle-income countries. And then what we've done, very similar to what Tanya was mentioning earlier on, that we provided these reports to centers. In fact, the centers came to us when we were writing this paper up to say to us, where are we? Where are we in the center? So this needs to be driven by centers. Centers need to be interested in these kind of benchmarks. Of course, we can impose them on them, but if they ask for it, that's even better, because that means there's stakeholder involvement. So in this report, which we provide to each center, we identify them themselves to say where they are as far as the sick day episode rates go. Now, does that have any use? So if you go to the next slide, what we can now, more recently, we've done this work again, and we're looking at a 3-yearly cycle. It's a lot of work to actually do this every year, particularly for rare diseases. So we're doing it on a 3-yearly cycle. And what you see over here is starting the work on the panel on the left over there in 2017, you can see that there was a gradual reduction in sick day episodes. Okay. But more recently, there's a suggestion possibly they've gone up. Okay. And this is possible. And I think benchmarks, you have to be very careful how you look at them. They are simple things, but they can be quite complex to interpret, because around 2020, you know that something happened called COVID-19. And at that time, because sick day episodes in children are related to respiratory tract infections, there are a lot of children were protected and they weren't going out. So it's possible the sick day episodes reduced because of that, rather than an actual activity of the center. But if you look at the funnel plots, which are on the right over there, you can also see these are the size of the centers is determined. Is illustrated by the number of patients per center, and you can see that the mean sick day episode rate, which is that red line, did fall for big centers and small centers. Okay, and of course the most reliable centers are the ones which are on the right over here, because those are the big centers, and you can see with funnel plots that the centers on the left are the small centers, well, putting not many patients in. So it's questionable as to how good their data are and reliable they are. So one just has to be a bit careful about when you're interpreting data in benchmarks from lots of different centers, that the size of the center does influence things a bit as to where that rate is. But anyway, but effectively what I'm trying to show, just next slide, Anna, thanks, you're moving me on, that's good. Is that simple condition-specific outcomes can be measured and they can be benchmarked. Okay. The challenge of ERN, such as endo-ERN, is the number of conditions they cover. Okay. So we can also say that, look, in the EREC, we can show that there are 35,000 patients who are being registered. Okay. But only a small number of them come into detailed benchmarking exercises. So how useful are those benchmarking exercises? That needs to be also thought about, because there are a small number of centers who actually participate in those kinds of things. I think where condition-specific outcomes are already being collected, ERNs can collaborate with existing sources of data, so they can develop those kinds of things for a small number of things. Okay, and I think when ERN registries like Eureka or any other registries in the future who are developing this, a lesson to learn from what we've done is that there needs to be very wide, a huge amount of stakeholder involvement in these things. And I think that's really important. And you need to think about the high likelihood of getting results. There's no point of actually just getting 1 or 2 centers doing it. I think there needs to be quite a few number of centers. But the critical thing is that it should be a small number of outcomes. There shouldn't be a huge number of outcomes. So you start off with at least one outcome, which can be used as a quality indicator benchmark, and then sort of move on to other things, because it's about trying to generate that interest in registries and the people who use these registries. So that's my sort of experience of this, and I'll move on to Anna.
Good afternoon, everyone. Thank you for having us today, Matt. Well, now, after Faisal's introduction, I think you all have an idea of what the registries in Eureka Urban are, the platforms we have, from the light touch EREC, collecting only the number of new cases, to the core registry, which is the platform where we can actually collect condition-specific outcomes. And I will go straight to what we call condition-specific modules. We've called them like this, but it's basically a data set collecting condition-specific outcomes. And over the last couple of years, 11 modules have been developed. Also, 11 study groups have come together, including experts in the field, patients, and with the objective of developing this data set and bringing it to the core registry to collect these outcomes. And you can see that, yeah, on the left, we see the year they were released or gone live in our platform, which condition they are focused on. And on the right, you can see who is leading the study group and also to which MTG the module is more related to. And in endo-ERN, conditions are arranged into 8 MTGs or main thematic groups, each of them covering an area of endocrinology. And also we have the 9th main thematic group, which is covering bone dysplasia. Today, we chose to focus on the FDMAS, which is short for fibrous dysplasia McCune-Albright syndrome. We think this is a very good example of what we've done there. So I will focus on that one today. And just very brief background. Fibrous dysplasia, I will just refer to FDMAS because it's shorter from now on. It's a rare and complex congenital condition. It is affecting bone, also affecting the endocrine system, usually with hyperproduction of hormones. It affects also skin with spots called café au lait. And it can also affect soft tissue with the appearance of tumors. It's a rare condition by definition, and the clinical spectrum is very wide. Therefore, there is a need to know more about this and what's been done in Europe and in the world with this condition. This is the study group of on FDMAS. As you can see, it is a multidisciplinary group, including specialists in different fields and also patient representatives. And they had the objective of putting together this module, starting, of course, by defining a data set and what needed to be collected. So this is pretty much the process in most of the modules that we have developed. Some of them, they skip a step or they start differently. But in this case, the first step was, of course, the interest of the study group. They proposed some variables. And here there's a collaboration between both of our registries of the platforms, because EREC, with the new number of cases, we saw which centers were seeing these patients, and we contacted them back. And even with just a number of, we saw 3 cases last month or this year, we saw this a number of cases of patients with FDMAS. We went back to them and we asked, can you please tell us a bit more about these patients, still keeping the data anonymous? Just we want to know what's the care pathway, the diagnostic pathway of these patients. How are you following them up? What kind of treatment they are getting? Are you perhaps collecting some outcomes on pain or quality of life? So we got these results, and together with the expertise of the study group, we had a final data set. And we built this data set into a beta version in the core registry. And this was tested by the study group. We made some changes. And finally, in April 2022, we released this version on our core registry platform to all users. And this module has outcomes for the clinician and for the patient to complete. And as Faisal said before, the patients can access the platform, and I will briefly explain you how this happens. It all starts with getting the informed consent of the patient. Normally, the clinician tells the patient about the registry, if the patient would like to participate and their data to be put in the registry, they agree. But we include here a question asking whether they would like to have access to the platform. This comes a bit later. Then the clinician enters the common data elements. And if the patient said, yes, I would like to access, the clinician can send from our platform directly an invitation by email to the patient, and the patient goes and activate via a link. The account is activated, and then the patient can have access. And sometimes we have been contacted by patients because they would like to join the platform, but the clinician, they don't know if they participate. So if that's the case, we invite you to get in touch with us. But this is basically how it happens. And then a patient with access to the platform, I will show you, this is a screenshot of a test case we have. And this is how the patient platform looks. And there are here many condition groups because this is a test case, but we're focusing today on the bone dysplasia group because here is where FDMAS lies. So the patient, when a patient accesses the platform, they can see what the clinician has entered, which kind of general data has been put in by the clinician. They can also edit their account details, they can change a password, and they can also request that the data is deleted directly from the platform. And when they edit some details, they can also choose a language, preferred language, and we have the language in the platform that can be, all the platform is displayed in a different language, the language of choice. Then going to the information of the specific diagnosis, there are also some data that is entered by the clinician, and this can also be viewed by the patient. And we also have outcomes that are specific to their condition. So as I said, we have 11 condition-specific modules, and we have many more conditions in the core registry. But for the conditions and diagnoses that have a condition-specific module, then the patient will also have a tab where there's a summary of the outcomes that have been completed, if any. So in this case, you can see that the platform also tells us when, who, and what kind of questionnaire was completed. In this case, the clinician completed an outcome and the patient can view it. And it also shows that the patient completed an outcome and the patient can view it, amend it, or delete it. Also, creating new outcomes is, of course, possible. And this is what the patient with FDMAS would complete. This is what the study group chose that was relevant to know from these patients. They would like to know how many health professionals they see and which are these healthcare professionals. Additionally, this is the information that a clinician has entered for this patient in the condition-specific module, and the patient can also view all this data. So just some numbers to show you what's happening there. In total, in the core registry, including the nine main thematic groups, we have over 3,300 patients at the moment. Of these, 637 are patients with FDMAS, and this reflects the drive of this study group. Of these patients, almost 80%, almost 500, have been entered into the condition-specific module. So this is a very high number. So that's the way we chose also to show this module. And you can see that we have outcomes that have been completed by the clinician, which is the highest number. We have almost 1,400 outcomes with a median of 2 per patient. And this is because more than one outcome can be completed per patient. And in the patient activity, we have 4 outcomes completed by 3 patients. It's also important to say that of the 637 patients with FDMAS, 131 would like access, and 51 of them have activated an account. So that's also a very good number. Besides the condition-specific outcomes, we also collect generic outcomes. And there's most study groups also give a recommendation on which outcomes or which prompts should be completed by these patients. For the FDMAS patients, we see that this is all data or outcomes completed by patients of these 51 patients that have access. 25 patients have completed the brief pain inventory short form, 17 of them the WHO mobility questionnaire, and 4 patients have completed the EQ5D questionnaire. What is expected from the patient? This is important. This is also a question that we often get, especially from patient representatives in the study groups. Well, it depends on the diagnosis. Some conditions have a condition-specific module, and some don't. The ones that do have it might have some outcomes for the patient to complete. If that's not the case, we have generic outcomes. As I showed, we have EQ5D, BPI, we have some others. And the clinician can set in the platform a request frequency, and the patient will get a reminder. The patient can also go to the platform and complete outcomes without those being requested. And like this study group for FDMAS, they recommended the BPI short form to be completed for these patients. So this tool looks like this. This is how a patient would complete the BPI short form. It has some questions and it has a body map where they can choose the areas that are painful. How do we guide the patient and try to be a bit helpful on what they need to do, how they can get to the platform? Or if you go to our website, there's a patient information page. There's a lot more information in our website, but here there are many resources for the patient. One of them is a patient guide. And this is a PDF file with a step-by-step guide on how to create the account, access the platform, and complete outcomes. Additionally, we have this feature when an outcome is due, the patient gets a reminder with a link that takes them directly to the page of the outcome they have to complete. So they first, of course, go through logging in with the credentials, but instead of logging in on the general patient information page, they get directly to the outcome. So they don't need to be searching what they are supposed to do. So this is something, a new development that we think that will also be very helpful. So in summary, the Eureka and Eurobond platforms can adapt to the emerging needs of the ERNs and the rare disease community, and this is exemplified by the work we're doing in the core registry. Having study groups with patient advocates and healthcare professionals as members, of course, ensures that the needs of both are covered. And Eureka and Eurobond platforms allow patients and clinicians to complete PROs and CROs. Thank you. That's covers all my part.
Thank you very much. Thanks, Faisal, Anna, and also Tanya for outlining how you've approached setting up disease-specific outcome measures and how you've used the registries to collect that information. If anyone's got any questions, please either raise your hand or put it in the chat and we can ask them. It was a lot of information. I just wanted to summarize some of it really to start a bit of a discussion. Faisal really raised the point that managed clinical networks like these ERNs, the main aim is to improve care for patients. And how we can do that, we've heard how the networks have identified disease-specific outcome measures and you have integrated them within your registries and you use them to do some benchmarking. I think Faisal, but you also highlight about those reports which centres want, and just I find it sounds easy if I'm honest. When you present it and the numbers which you've got in terms of the registries, I think they're quite difficult things to set up. So maybe you could explain in ERCnet or in ENDO-ERN how you sort of got good support and engagement of the healthcare professionals, the clinicians, to want to do this, and rather than it being seen as an additional task. Oh, this is more administration and burden. How did you incentivize the clinicians to take part and to develop these outcome measures and to actually collect the data and input, because that takes time. I don't know, maybe Tanya, you'd like to go first. You're muted.
I'm sorry. Yeah, no, we see that we have really a lot of patients in our registry, and we really appreciate all the efforts our centers are doing. But of course, we also needed to provide some incentive, and the easiest thing is to compensate their time to include their patients. So we have a case-based compensation method in place.
Okay.
So they get money for each of the patient they entered and also for the follow-up. But of course, not only the money counts, also we are fostering research projects, doing analysis with the ERCREC data so that they can also benefit from co-autorships or leading autorships.
And you also said that, you know, having that direct, I think with one of the features I really liked about your ERC reg is if I put my patient in, you know, diagnosis and what the treatment outcomes are, that I get direct feedback at that point in time. That's also an incentive, isn't it, really?
Yeah, actually it is, yeah. So they can continuously log in into their own dashboard and see how they perform with the ERCnet average. It's calculated in real time, so whenever a patient is entered or being updated, they get the new information.
Brilliant.
But it's only the continuous self-monitoring. Also, we received a really good response that the PDF files we send twice per year, that they really go through it within their team. They are checking where they can improve, and then they go back when they maybe spot some discrepancy and say, oh, but this must have been correct. So we go back into the database and check maybe it was the case that there was a misunderstanding in entering the data. So yeah, it's also important to keep the data clean and correct.
I think my experience is quite a sensitive area, working with clinicians where data might be you're an outlier. What does that mean? What does that say? And to have an environment of trust where people feel they can be transparent about that. I think that takes a bit of time to get right.
Yeah, but we really communicate with them that it's not monitoring to blame them or to say we're doing worse. We are doing this to help them improving areas and to find solutions to get better patient management in their center. We are not saying you do worse from all ERCnet centers. So yeah, that's very important to say.
Great. I mean, Anna and Faisal, and you also presented some other registries which you're involved in internationally. So how do you get the clinicians to sign up to this, you know, when it's quite sensitive?
Yeah, I think the two different levels, there are actually different levels of work which needs to be done here. And I think we missed a trick when we were developing the ERNs right at the beginning. And I think amongst the critical features or qualities they had to have, we never thought about them having resources for database administrators or having we thought about having an endocrinologist or a psychologist or a physiotherapist or an occupational therapist or someone like that. But we never thought about who I think they're the backbone of a care quality network, which is actually data crunching and putting data in. And I think, you know, the business of incentives, like giving money to some people and some, I think it's fine, but I'm not completely sure whether it's a long-term sustainable thing. Whereas whether there needs to be something which is a quality of a center is that their ability to be able to collect data and put data in at a regular way. So I think from that point of view, I think that's something we've realized in other managed clinical networks or care networks. That's an essential part of the team which needs to be resourced. And it doesn't have to be for one particular ERN, but that person could be spread across lots of ERNs at any one center. So I think that's something which needs to be thought about. But your other point is as far as benchmarks go, and again, what is a characteristic approach over here? Well, I think I know from the international work we did, we could never enforce this. But what we found was when we started looking at these things, the clinicians themselves were coming to us and saying, actually, where is our center amongst these data? And they wanted to know. So the drive was coming from the healthcare provider as to whether they wanted. So they realized that this was an important thing and they wanted that. And I think that needs to come through. And I think it needs to be inculcated at a very low level. But I think that's an issue with culture. And I think if people are fine with it, and I think that's okay. But I think the healthcare delivery system is quite varied in different parts of Europe and different parts of the world. And some people will feel threatened about this and showing whether the patients will then start moving to another center and won't be if this was publicized in some shape or form. So it has to be done very carefully. And it has to come through, or it's somehow there's a thing which says, there's a directive from higher up which says that has to be done for a certain thing, and that has been done for cardiac operations in children, for example, there is a national directive in several countries which says that you have to collect this data and you have to publish it and you have to show it. And if that was the case, then that could be healthcare providers would take that on.
Brilliant. I see
Long
Tanya.
answer.
No, it's I think, you know, as a commissioner, we were always curious and wanting to understand how this information was being used and what was the improvements being taken place. So it wasn't, oh, you're performing poorly, or you know, compared with the other centres, your mortality rate has increased significantly. We were interested in, over the last 12 months, how have you used this feedback, this data, to improve services? What have you done to strengthen what you do? What was your learning? So I saw, Tanya, that you've answered the question, I think, in the chat already from Raquel. So is there any questions anyone wants to ask live? You can't be all shy. So the bit for me is that culture of learning. So maybe, Tanya, in ERCnet, you've got this. I love the connectivity of your registry with this data is being collected well, and it's based on your guidelines, and so you can see the adherence levels and ask questions and almost go back to the guideline and update the guideline based on the knowledge you're generating. It's a brilliant feedback loop. But is there a space you have in your network where the clinicians come together to discuss that data, their data, so they can, in between, because, you know, to glean what another centre is doing well, that emerging best practice, really? Have you created that space yet?
Yeah, so Karen, in the past, during the working group meetings from the various thematic areas, always the KPIs from their own disease group were reviewed and discussed, where there are areas of excellence, where improvement was necessary. And now we also started to form dedicated KPI task forces within the working groups, who just sit there, evaluate the results, maybe reassess performance indicator, which is not anymore worth to keep in or to add new. So currently we have some of these KPI task forces in place who work towards an improvement.
Sounds very dynamic, a KPI task force. I want to join one of those. I'm in.
You're invited, yeah.
I'm just conscious of time, so maybe we can have Johan explain really about how patient representatives have been involved. We've seen a bit from Faisal's presentation, and Anna, the 3 or 4 patient representatives in one MTG, if I get the lingo right. But maybe you can shed a bit more light on that, Johan.
Yeah. Thank you. I will share my screen. Hopefully it works. Yes. Okay, thank you for the invitation. And when we talk to patients about registries, we ask them, what is the most important thing for you? Well, they say, I want them to learn more about my rare disease, and I want to help others getting a diagnosis sooner, because a lot of patients are struggling getting a diagnosis because of the rarity of the disease. And also sharing of the data is important because of the low incidence of the disease. And my condition is so rare that I'm happy with any research performed. But then when you're talking about the subject with patients, they're starting to ask questions. How safe is my data? Is my privacy guaranteed? Would it only be used for medical purposes? And is there a role for pharma? Also, is it the patient that is benefiting the most from a registry? And what is the role of the patient itself in the registry? And some said, well, we would like to share data, but not everything. And also some patients said, well, we would like to be informed about the results, and how and where is my data stored, and who's responsible for checking the safeguarding of data. So those are questions that patients ask when talking about registries. And we did also a small survey and presented that in a poster during a Congress of the inauguration Faisal at Leiden University in 2023, together with my colleague Arlene Smythe from the Turner Syndrome Support Society. And asking patients, can the data be shared? 100%, almost 100% said yes. And would you like to be contacted for future research purposes? Over 95% said yes. And can it be contacted for collecting reported outcomes? Almost 90%. And we also asked the question, would you like to access your own data? And that's just over 50%. And about 40% said, well, I would like to receive newsletters. Another task we have as patient representatives is informing the patient community about what registries are. So we had an article in 2021 already from Marco Roos from the Leiden University talking about fair data, because for patients, that's a new thing to learn. And also Professor Faisal Ahmed wrote an article about the use of registries and the benefits of registries. And we received some feedback from patients, and they said, well, interesting, but very technical and difficult. And we received also a number of compliments, and those were from patients with an IT background. And even I remember one who was working at the Ministry of Health, compiling data and numbers about illnesses. So it was difficult, but it's important to inform everyone about registries. When we look at ENDO-ERN's mission and the registry-related activities, you see that ENDO-ERN is there to reduce inequalities in care for patients with rare endocrine conditions. And the patient representatives, the EPACs, are involved in steering committee, and they have a role in the registries. And the Eureka project, Faisal talked about the name, aims to capture the patient's voice in the registry by incorporating the patient-reported outcomes, and they're very important. And also, patients are involved in the governance structure, not only within ENDO-ERN, but also the governance structure of the registry project. And we also had, one of the projects we did was measuring the needs of patients via the Delphi method, and also guaranteeing that the patient has access to their own data, and that's what Anna showed. Looking at how it was all organized, we started with a work package held at the beginning of ENDO-ERN, just after the founding of the ERNs, with the work package Research and Science. And within the work group, we did a big survey targeting all endocrine patients all over Europe, asking what their unmet needs were in clinical research. And that's a nice start. And we also saw, that was one of the findings, that over the different MTGs, the main thematic groups, the 8 we have, that patients also have corresponding views on what's unmet need in research. After that, there was a work package Eureka, Patients, Parents, and Ethics, was also mentioned by Faisal or Anna. And we there try to understand the needs and expectations for patients, parents, and the families in registries, and ensuring that the patient's focus is maintained in the development of core outcomes and the core endocrine registry, and also developing a clear ethical guidance for the operation of registries. Appraisal of the extent of patient involvement and patient safeguarding in existing disease registries, and of course, involving patients in the dissemination and evaluation process. Also, I think it was Faisal or Anna, not sure anymore. There is a steering committee and a patient advisory board. In both, there are patients working. And in the steering committee, there are 2 patients, and they're revolving within the steering committee. So there are all patients at certain times. What we do is, in those patient advisory boards, we give input on what's important for patients. And also there are study groups and working groups. And the working groups I was active in was the working group, the condition-specific module for pituitary disorders. And that's also in the registry right now. And that gives the possibility to go deeper into detail. Coming back to the poster I talked about at the beginning of the presentation, patient-reported outcomes are questionnaires to be used to study how patients feel about their own health status. And the positive effects are identifying the unmet needs in patients, providing feedback on treatment effects, and improved communication with the patient and family and professionals, and also an instrument for quality management. And looking at the advantages, it's a possibility to see certain patterns and same concerns across the patient groups, because a number of patients are small within one center. Combining those centers can give another view of how patients are doing. It helps a direct need for research. Patients are willing to share the prompts to help others, as said in one of the previous slides. And identification of unmet needs, feedback on treatment effects, improved communication between the patient and family, I thought already. Yeah. And there are also a number of disadvantages. Sometimes it requires additional steps to gather evidence about what patients are reporting. And also, because you're talking about rare diseases, the numbers may not always be high enough for a direct change. And there are also limitations in the use of prompts during the consultations, and also it can also raise unrealistic expectations for care because patients have filled out their unmet needs in the prompts, and they maybe accept a solution for it. And also maybe it's not a suitable instrument for all patients. What we also did, we communicated about it in 2021, but we were very happy that this year in 2024, it's all in Dutch, sorry, we don't have an English version of it, but we made an article written by Lauren van der Hoeven of the Amsterdam University Hospital, that patients, well, explaining what the registry is about, but also that patients have the possibility to join a registry. And this is how we inform patients to get involved in a registry and have the possibility to talk with a doctor and also know what about it. And we said, there can you find the information on the websites of Eureka. And this article was very well received by our patient community. And also one other example, we are always involved in the congresses for registries. So my colleague Petra Brugman did a survey on unmet needs for a specific MEN disease and presented that on the recent registry meeting we had in Milano this year. And this was my contribution. So I stop sharing my screen.
Thank you, Johan. So prompts really are one of the key aspects to include as well to complement clinical outcome measures. And I'm just, how are they used, or how are they used within Endo ERN to aid care on the go, rather than be something which is used, 2 years down the line for research? Can these prompts be something which can be used in everyday care? Tanya's raised that the clinicians get direct feedback on the clinical outcomes in ERCnet. Does the registry, your core registry in Endo ERN, allow for the clinicians to see that data in real time?
Maybe Anna and I can take that.
Yeah.
I think there is we've got to be careful about this because if we start using it for clinical management, then there is a clinical governance issue here.
Okay.
Where the data are being used at an individual patient level, and then where are they being stored in the registry, or will they actually move into clinical records? And I think from that point of view, that is something which we've discussed. There is a place for, as soon as a person completes the outcome, the PRO, that a notification goes to the clinician to say a PRO has been completed, and that happens, and then the clinician can look at that data. I think we have to explore that a little bit more as to how that fits into the clinical governance issues, as to how, do the registries become liable for that, or do the clinician takes responsibility for that, for using that data? And patients can complete it. They can effectively complete it all the time if they wanted to, although there's a required frequency of once every 6 months, once a year. They could be completing it every few days. and then a notification will go to the clinician that that's been done. But there are other things you're suggesting, Matt, because what can happen is that the center could get an aggregated report for all the PROs at regular intervals for their patients compared to what the benchmark is. So there are a few different things which could be done. Yeah, I could carry on, but I'll stop there.
Okay. So I think, Johan, just in terms of patients' involvement in the MTGs, if I'm getting the lingo right, and defining those disease-specific outcome measures, you highlighted that you're involved in the discussions and also in the survey. What do you feel? Did you feel like your voice was heard? Did you shape the outcomes in terms of the relevance of them? Were you happy with the outcome? You know, the measures which were made for maybe for your condition you represent. Do you think they are reflective or a good indication of how the condition is and responding to treatment?
Yeah, well, it was very good. We got in the process of developing the survey. We were involved in that. And also we have periodical discussions with the group responsible for pituitary disorder. So we have the opportunity to do a say. But it really helps now as a patient that also I have access to my file. And before that, it was rather abstract talking about registries and not knowing how a registry looked like. So now I have the opportunity to fill out my own data. And hopefully that also works for other patients so that they got more familiar with the concept of registries. Because in the years before that, we were only talking about a registry important for research and everything, but the patients didn't see directly what's in it for them. And I think that's very important. Okay. And well, looking at the specific file I have, I can enter a number of quality of life aspects, which we talked about in the specific MTG pituitary group. So that reflects what we are talked about, and that's in the registry now. But for patients, it's very important to experience how a registry works and also how it can be important for them. And already they know that, but I also think they have to see it. And we have now had a number of articles about registries. I don't think it will be the last one. We have to stay communicating about it and because why it's important for patients.
Brilliant. Thank you, Johan. I've got one big last question, but I want to see whether anyone else would like to raise a hand or ask a question from the participants. Otherwise, I'm hogging the questions, which I'm quite happy to do. So you can put a question in the chat or raise a hand. So whilst people are thinking about that and reflecting on the presentations you made today, you know, I highlighted at the beginning that I know of your two networks, Endo, ERN, and ERCnet, as being networks which have prioritized and put these outcome indicators central to how the network functions. What do we need to do to really mainstream this across all the ERNs? Why haven't we got there why is this not being prioritized in other networks? And is there something we can do to sort of enable the other networks to move forward, to follow suit, and to the reason why I'm asking that is when we had the recent evaluation, one of the criteria was, has the network developed a registry? And it was yes or no. And a stretch target was, have you developed disease-specific outcome indicators and collect on it? So it is considered a stretch target for where the ERN system is now. So what do you think would help enable us to move the whole ERN system to use disease-specific outcome measures and collect them? It's a big question.
I could take that on. So I intimated this earlier on that I think in the quality of the evaluation process of the ERNs, we need to not just ask that question, which is, has a registry been created, but it has to be something more than that. And I think even for the question about disease-specific outcomes or condition-specific outcomes, that itself can be, what's the word I'm looking for? It can be answered in lots of different ways. And I think we need to go possibly that should maybe the basic question, which should be the mandatory question. But I think we need to gradually move the ERNs towards more care quality indicators or whatever you want to call them. So these are KPIs which are saying something about care, which is assessing care in some shape or form. I think that needs to come. So yes, it was a loaded question, Matt, but I agree with you. I think we need to move that goalpost a bit.
I've never been accused of doing a loaded question, Faisal. Maybe Tanya, what's the learning which you know, has there been challenges for you in setting this system up, and what would be your advice to another network which would want to develop these? You're on mute again. You're very good with your mute button.
Yeah, okay. Yeah, so we already started with developing the registry back in 2018, and Franz Schäfer, our coordinator, already had a vision to include the KPI monitoring into the system. And I think he also tried to put this idea in the efforts of the other ERNs. We were one of the 5 who got funding in the first period, and then the others got the funding later. And I think we always showed our system and the benefit of it. And yeah, I think it's different because all ERN registries are set up differently. Some are just a core registry, others are a little bit bigger. But yeah, maybe we should internally, also through the project managers, make more advertisement to make them some programming efforts into the KPI system.
So Patricia said in the chat that she agrees that access needs to be extended to patients, so we can contribute usefully to putting data in directly. Even in the UK, the experience that this doesn't happen routinely. So maybe the registries need to be more multifaceted, and we need to then look at really then how much investment and how we can sustain the registries to become really a bit more high level of functionality for the ERNs, because I think that maybe it's there's a funding issue there. So I mean, my last point really, and what struck me, you know, counting how many guidelines networks have done or how much training doesn't really show the quality of the network. It shows the productivity of a network. And, you know, I'm really struck by both networks and how you can actually show how care is being improved, how the outcomes of people's lives are being improved by how you set yourselves up. So I think moving, as Faisal highlighted, to a system which is more based on care quality indicators, which can show the improvements that, you know, each of the networks have done over 5 years or 10 years to standard care, I think would be really compelling and more political focus, I would suggest, or more airtime with the Commission and the Board of Member States. Maybe that's the focus which we should have in future rather than where we've come from. So we have to shift the discussion across a bit. If the Commission's interested in how many patients you've seen, then you're producing output information. But if the Commission's asking you, you know, how have you improved care over the last 5 years, you know, you have to develop a different system and a different way of doing that. So I think that that's an important shift which we need to make on a strategic level or a policy level in the ERNs. I don't know whether you've got any, we're nearly at the end of the webinar, whether there's any final points you want to make. Maybe Anna, you first, whether you agree or not.
Yes, I would just like to comment as well on just there were some questions in the chat about what are other ERN registries doing or which platforms are they using. And I think for me joining last year, some of the ERICA meetings, it's more focused on research, but there was a lot of work done around all the aspects of the registries. And I think we were already set up, but it was very interesting to realize that different ERNs were doing different things. Maybe they were still starting to get an idea of how they would set up a registry. And on the other hand, there were other ERNs with that were already more advanced, and that for them, they said, okay, it would have been useful to know this before. So I think it's also very important to have some communication between the ERN registries, yeah, to help each other and to know what we're doing, and also to try to be fair, to go towards the fair path. Yeah, because that way we ensure that data is collected in a more yeah, similar way. So yeah, that would be also my comment. I think there was a question that was partially answered.
Brilliant. Thank you for keeping an eye on the chat as well. Faisal, any last comments from you or observations?
Yeah, I think Anna makes a fair point. I think there's some of this is an issue with competition. I don't think there should be competition here between registries and things. I think there needs to be collaboration and exchange of how things can be done better. Because at the end of the day, things like quality indicators and all that kind of stuff, or KPIs, as Tanya mentioned, the concepts are the same for everybody, and it doesn't really matter which registry we're talking about. But some of us, as again Tanya said, have just been doing it for longer. So we've been there. We've seen what the easy things are, low-hanging fruits are, what the high-hanging fruits are, and we can help others as well.
Brilliant. Thank you, Faisal. Tanya, any last comments from you or observations?
I can just share Anna's and Faisal's view that we should help the other registries which are not such advanced as our tools in improving their system. And we are there to help, so each registry can get in touch with us for asking for help.
Brilliant. Thank you. Johan, from you, any last observations?
No, not specifically.
So we had a comment in the chat saying from Lindsay saying would love to see a central registry for rare and complex conditions in Ireland that could be possibly connected to the ERN registries. We've not really touched on the joint action and how that's looking at the data side. I think that's another webinar in itself. But interoperability is essential. So on that point, I would like to thank Anna, Faisal, Johan and Tanya for your presentations today and taking part, and I'm really excited to see how we can move forward, move the ERN system forward to being more focused on the quality of care, care quality indicators, and change the culture a bit from looking at measuring outputs to outcomes. So thank you very much for today, and we put in the chat briefly a survey, if that's okay, Andrea. But thank you very much, and we'll make the slides available, the presentations available, and thank you very much.